Thank you very much for this invitation. This talk is going to be on hydronephrosis in children. So in the past, hydronephrosis used to present like a mass abdomen, and over the years, the entire natural history has changed. Nowadays, it is presenting as antenatal hydronephrosis, which means the baby is already born. So we have more questions than answers. When it is severe, how extensive to evaluate, why does PUJ obstruction occur, when to intervene, which option is better, how to define success, how to define failure, multiple questions we have in our mind. My slides are moving, right?
Yes, yes.
Yeah. So the Society of Fetal Urology grading has been in vogue since 1993. One of the biggest advantage of Society of Pediatric Urology grading is you do not rely on the report, but you look at the ultrasound and you can tell what exactly is the grade of the hydronephrosis. So if there is completely solid, then you know that it is a grade 0. Then there is a minimal dilatation is grade 1. Then some more dilatation of the pelvis, then dilatation of the calyces, and there is a cortical thinning. So this is the Society of Fetal Urology grading of hydronephrosis. Now, the anteroposterior diameter is another important factor in the grading of the hydronephrosis. So the normal values are established for each trimester. So in second trimester, it is 4 millimeter, third trimester, 7 millimeter, and after birth, it is 10 millimeter, above which we call it a hydronephrosis. So anything between 4 to 7 is mild in second trimester, 7 to 10 is moderate, and more than 10 is severe in second trimester. Similarly, in the third trimester, 7 to 9, 9 to 15, and more than 15 is severe. After birth, again 10 to 15, then 15 to 20, and then more than 20. So that is how we grade the severity. One other important thing which you need to note is when you look at that anteroposterior diameter, you have to remember that measurement is done at the level of the isthmus. So this is the anteroposterior diameter and not any other diameter. So our experience, we published this in 2010 in antenatal hydronephrosis. If the diameter is less than 15 millimeter, almost none of them warranted surgery, and that can be an important point in the counseling of these patients. Now, these were the revised guidelines on the management of antenatal hydronephrosis. So there, they mentioned in year 2003, and then they republished in 2013 with the revised guidelines where they recommended a maturing cystourethrogram in MCU in all children with hydronephrosis and a diuretic renogram in all children with more than 10 millimeters. But we were following this protocol and then we audited it. And then we showed that, when there is no hydroureter, there is no point in doing an MCU because you don't pick up the abnormality. Similarly, when the hydronephrosis is mild, like 15 millimeter, then you don't. So we have revised our protocol. And nowadays, in a boy with bilateral hydronephrosis, we do an ultrasound, we do a MCU to rule out a posturethral valve. On the other hand, in children with more than 10 millimeter hydronephrosis, we go by the hydroureter. If the hydroureter is absent, then we go for the further evaluation based on the size. If the size is less than 20 millimeter of pelvis, then we just follow them up. But if it gets increasing to more than 20, or if there's a cortical thinning, then we go for a diuretic renogram. And if there is urine infection, then we go for a voiding cystourethrogram. But if there is hydroureter, then we do the VCUG first because we want to make sure that there is no vesicouretic reflux. And sometimes these patients have an obstructed megaureter also. So we have to evaluate accordingly depending upon the way it progresses. Now, the UTD classification has been in vogue recently. So it looks at 6 factors in the antenatal period: anteroposterior diameter, calyceal dilatation, parenchymal nature, ureter, bladder, and Leica status. In the postnatal also, they have the same thing, but except the Leica status. So that is how a UTD P1, P2, and P3 are there. And in the postnatal period, if there is only a mild hydronephrosis of 10 to 15 millimeter, then that is a low risk. Then if it is more than 15 and there may be ureteric dilatation or a peripheral calyceal dilatation, that is a grade 3 hydronephrosis, then you have a P2. when you have this cortical thinning, or when you have the bladder and ureter abnormalities, and it is called P3. We looked at the UTD classification and then its the role, and then we also found that the UTD classification is very useful in the sense that if it is A1, only 20% had a persistent abnormality, rest of them is resolved. But if it is UTD A2 to 3, then 80% had a persistent abnormality, and then half of them, one third of them needed an intervention. So this classification is useful, but at the same time, there are some problems with this classification also. UTD is input to the radiologist to reassure the parents, and they are also be able to refer the case to a surgeon, because if it is UTD A2, 3, they can refer to a surgeon. But when we are at the receiving end, for the surgeon, it doesn't give you the actual benefit of what exactly is going on. So it includes a wide variety of congenital anomalies. You can even have an MCDK, you can have a duplication, you can have multiple abnormalities. So it does not suggest who needs a treatment and who should be followed up. So a good sonologist is a great boon, because you need to get the fine details. And then we sometimes look at how thin the cortex is, and we look at the pelvis cortex ratio. So this is something which we looked at, and then we said that if the pelvis cortex ratio is very high, then they all need pyeloplasty. Then one more thing is the ultrasound elastography. So we have looked at this the shear wave velocity, and we also found that that is useful. Now, diuretic urinogram is another important test in determining what happens to these children. And so this diuretic urinogram, we have looked at multiple factors on what all happens. Now, let me illustrate this with a case. This is a 2-month-old girl with antenatal hydronephrosis. The AP diameter was 24 millimeters and calyces were dilated, but the cortex is intact. So this is grade 3 SFU. The renogram is sluggish, but it drains. So this is what it is at the moment. So because it is draining, we tend to wait in such a case. But at the same patient, after some more months of follow-up, the cortical thinning has started. The APD has become more than 30 millimeter, and there is no drainage on the diuretic renogram. So this is when we take a call to go for intervention. Yeah. So that is when we go for an intervention, right?
Bluetooth
I request others to please mute your phone, please. Can you please mute your phone? If the others can mute the phone, I can talk. Yeah. So we also introduced this hydronephrosis severity score, where an objective assessment of hydronephrosis severity was performed based on the classification and then grading. So we proposed this, where we use the SFU grading, we use the drainage pattern, and we use the differential function. And when we add them all together, we get a score of 12. So one is ultrasound grading, which you have already seen. Then other one is a drainage pattern, where this is 0 is normal. This is the drains after the Lasix. This is drains before the Lasix. Then this is a sluggish drainage. This is a flat drainage, and this is an upgoing curve with the stasis at 2 hours. So this is a sequential grading, unlike O'Reilly curve. O'Reilly curve grades them in 0, 1, 2A2, 3B, 3B, like that. But this is a 0, 1, 2, 3, 4 grading. Then also based on the function, if the function is dropping from 45 to 30, then it gets more severe. So we looked at it, and then when somebody has got a grading of 9 to 12, then almost all of them warranted a pyeloplasty. So this is something. In the post-operative period also, this can be helpful. So it's a pre-operative grading and then post-operative grading, how nicely it has improved and how nicely it has started draining. So this is useful marker in pre-operatively, and it's an objective tool, and it's also effective in the post-operative period. Now, conventional indications for pyeloplasty were drop in split renal function during the follow-up in the presence of an obstructive drainage or grade 4 hydronephrosis. Now, in the past, people used to wait for the loss of function. But what happens is, when you do a late pyeloplasty, like waiting for the function to lose, the gain in the function after the pyeloplasty is not much. Whereas when you intervene at appropriate time, then there is a good improvement in the function. So early pyeloplasty in a prenatally diagnosed grade 4 PUG obstruction leads to significant improvement in SRF, whereas delayed pyeloplasty leads to a marginal but significant loss. So this is an important publication which we made in 2015. And the same has been, the case reported by several others, where the functional outcomes of pediatric laparoscopic pyeloplasty in infants is much better than the older children. And in the 1 to 3 month age group also, it is much better improvement in renal function than the others. So can you predict which case will lose the function during the follow-up and preempt the pyeloplasty?
Okay, sure.
So this is where the role of urinary biomarkers are there. So these are important to differentiate the non-obstructive dilatation from a pelvic junction obstruction. So we looked at the accuracy of the biomarkers, and we found that there are two biomarkers which are most useful in picking up the hydronephrosis, the severe ones from the mild ones. So when we looked at it, this all these biomarkers are elevated. The CA19-9, the lipocalin, and kidney injury molecule, they are pretty useful. And then picking up the severe ones. And then when you combine it with an ultrasound, it becomes a very good non-invasive test in differentiation of uretropelvic junction from non-obstructive dilatation. Now, what do you do in those with the bilateral hydronephrosis? If there is a bilateral grade 4 with a mass, then you can possibly say that we will do the worst affected side, or you can even do a bilateral pyeloplasty and then bilateral stent removal. But if there is no mass, then you do one side pyeloplasty and then stent removal and then contralateral pyeloplasty and then contralateral stent removal. But if there is a grade 4 on one side and grade 3 on the one side, you generally do the grade 4 first. And most often, by the time you come back for stent removal, the opposite side usually improves. So that is our usual approach which we have done. What about the poorly functioning kidneys? We have looked at this histopathology, and then around 80% of these patients with the poorly functioning kidney have got the interstitial fibrosis and tubular atrophy. So we generally recommend a period of percutaneous drainage. After 4 to 6 weeks of drainage, around 1/3 of them improve. But if there is no improvement, then probably a nephrectomy is a better choice, particularly in those with less than 10% function. Now, not reducing the pelvis, we nowadays we are doing laparoscopic pyeloplasty and then not reducing the pelvis. So we've been looking at the follow-up, and then even those with the large pelvis more than 40 millimeter, we do not reduce the pelvis, and then they are coming down nicely as they follow up at 6 months to 1 year. But the only thing is the pelvis size is like a belly size. Once blown up, it never comes back to normal. So we have to tell them in advance that once you blow a balloon, it doesn't come back to the previous size. So this is important as a point of counseling. So the presence of a little dilated pelvis like 10-12 millimeter after surgery is not necessarily an obstruction, because you started at 50 and you end up at 20 to 10, which is a pretty good improvement. So again, these ratios and the scorings, there's a score called Pyeloplasty Prediction Score. There are multiple scores to reassure the parents. And kidney size is another thing which improves. For example, if the kidney size is quite big compared to the other kidney, then it becomes matching after a period of surgery. So the kidney size is also another important. Urinary biomarkers, again, we have looked at it. They fall significantly and rapidly after surgery at 6 weeks and 2 months. So if somebody is worried about the persistent dilatation, then biomarker is the answer. So that is an important finding. Then recurrent uretropelvic junction obstruction, we do a redo pyeloplasty usually, but we can do a flap pyeloplasty or a ureterocalicostomy. Now, this is a systematic review and meta-analysis of open versus conventional laparoscopic and robotic pyeloplasties. And we concluded that robotic pyeloplasty has slightly longer duration of the surgery, but shorter hospital stay, and then comparable success rate between robotic and laparoscopic pyeloplasty. But when it comes to infants, then laparoscopic pyeloplasty still is better because RALP in infants has got a significantly longer duration of surgery, longer hospital stay, and higher complications. So some of the take-home points I want to say is anteroposterior diameter alone is less important. calyceal dilatation and parenchymal thinning are the important points. Initial split renal function less than 40%. You have a low threshold to wait and do not promise functional recovery. Always warn of a residual pelvis size. Diuretic renogram curves, T-half and cortical time are unpredictable. In grade 4 hydronephrosis, early intervention in infancy recovers renal function, while waiting may lead to an irrecoverable loss. Biomarkers are very useful in diagnosis as well as prognosis, and recurrences to be diagnosed only when there is a functional loss or pain. Just because some dilatation is persisting, then you don't see that they have a residual obstruction. So that is in short about hydronephrosis. Now I'm open to answer questions, anything if you have. So please ask questions if you have any. Someone has asked indications for nephrectomy. As I told, in those with a poorly functioning kidney, like less than 10%, we do not do a nephrectomy straight away, but we do a trial of either internal or external drainage. Internal drainage means we leave a double stent from cystoscopic method, and then that drains, or we can do a PCN for a period. And if the function improves, then we can say that okay, we can do the pyeloplasty. Now the function is 10% or 5% is a big debate about it, because you know what you determine when you come to compare 10 and 5, it becomes very inaccurate. So you have to look at the cortical thickness. Ultrasound becomes very important. When you have a paper thin cortex, even what looks like 10% may not be 10%.
Thank you, Dr. Ramesh. In
Yes,
fact, we have very elaborate discussion on pediatric hydronephrosis. Very interesting. Is there any question from the audience? Any question?
A very nice presentation, Dr. Ramesh. I am a pediatrician, and we encounter in our day-to-day practice. This is a very common case for us, and most of the time, parents move to us with antenatal ultrasonography, and they ask what to do next. So, what is the critical time for a pediatrician to refer to this type of cases to a urologist? First. Second, what are the danger signs for immediate intervention for a pediatrician or a urologist? And third, in case of mild hydronephrosis, generally we recommend follow-up ultrasonography at 4 to 6 weeks of interval or 3 to 6 months of interval. If anteroposterior diameter of the pelvic calyceal system is maintaining at the same pace, then what to do at the next level?
Yeah, thank you for the wonderful questions. And they are all very relevant because nowadays, a lot of parents get worried. Even with the mild hydronephrosis, they even go to the extent that can I terminate the patient? On one hand, we have to evaluate these patients. We have to reassure them also because, you know, some of the grade 1 society or grade 2 hydronephrosis or UTD1, they are all safe, absolutely safe. Mostly 99% they will not need surgery. When you have a grade 3 to 4 hydronephrosis, that is when you get worried. So that corresponds to your UTDA 2 to 3. So they have to be closely followed up in the postnatal period. So we generally avoid an ultrasound within the 72 hours because they are usually dehydrated. So you do an ultrasound and that is normal. They don't produce enough urine. So you are falsely reassuring them. So we always have to get an ultrasound at 1 month of age. So at that point, if the SFU grading is less than 3 or it is UTDP1, which means the diameter is less than 15 millimeter. There is no calyceal dilatation. There is no cortical thinning. We can safely reassure them. Around 95 to 98% of them will not need surgery. Now, if they have more than 15 millimeter dilatation, calyceal dilatation, cortical thinning, we cannot reassure them. We have to say them that you please come back for a repeat ultrasound at 3 months and a DTPA scan and maybe an MCU if the child gets a UTI or there is a ureteric dilatation. So that is when a proper evaluation starts. So that time we have to refer to a surgeon for further evaluation and then maybe an intervention. I hope I'm clear, Dr. Raza.
Yes. Thank you. Thank you, Dr. Ramesh.
Yeah, thank you so much.
Dr. Ramesh,
Yes,
is
sir.
there any place for PCN in these cases and wait for some time and reevaluate to
Yes,
see the recoverability of the function, kidney function?
it is
there a
only when the
place?
function is really low. When the function is like less than 5 or 10%, then in those patients, we do not recommend for a nephrectomy immediately, but we do a PCN for 3 to 4 weeks and then reassess the function with the DMSA scan. If the DMSA scan shows more than 5 to 10%, then we can go for a pyeloplasty instead of a nephrectomy.
Any more question? Anyone?
Thank you very much for listening to this.
Hello,
Yes, sir.
Dr. Ramesh. In the case of prenatal diagnosis of grade 1 and grade 2 hydronephrosis, what are the chances of complete recovery? How much % of patients recovers spontaneously and how much needs treatment?
Yes, in prenatal hydronephrosis, if we look at the overall, all hydronephrosis, around 70% of them recover. So the transient hydronephrosis is quite a huge number. And then in the 30%, again, another 20% keep on lingering with either a reflux or a mild hydronephrosis where we still have to keep on evaluating. So only around 10% are severe ones which needs a pyeloplasty. So we know that antenatal diagnosis itself is not a major thing. Now, someone has mentioned that is split renal function less than 35 an absolute indication for pyeloplasty. We do not go like that. We go by the curve, the drainage pattern, and then how the hold up in the late film, then cortical thickening. So when you have a combination of factors like less than 40% function, there is no drainage at even 2 hours, and the ultrasound wise cortex is thinned out. You have a combination of these 3 factors, and then you go for surgical intervention.
Any more question? See, there is a question from audience.
Yes.
Which scan is preferred, EC or DMSA or whatever you recommend?
EC scan is preferred,
DTPA.
sir, because EC scan has got both available. Mac 3 is even better, but Mac 3 is pretty expensive and it is not widely available in India. EC is available, and I would go for EC rather than a DTPA, which is purely a GFR based test.
Okay, EC scan.
Yes.
Any more question?
What is the reason for failure? How much do you dissect in a pediatric case? Both UPG or upper ureter. The reasons for failure of pyeloplasty.
Dr. Ramesh
Yes, sir.
Babu, have you heard the question? Actually, his question is, what is the reason of failure of pyeloplasty? What is the extent of dissection, UPJ and upper ureter? What are the technical reasons which could be a factor for the failure of pyeloplasty?
This is a very important question because lot of people think that reduction of the pelvis is the most important thing, but it's actually splaying open of the ureter until you see the normal mucosal rugosity and then thick wide ureter. So until you splay it open nicely, it will not start draining because it's basically an adynamic segment, and that is the reason for a failure. Another reason for failure can be a leak, perinephric leak or missed lower polar vessel. But the usual reason for failure is we have not splayed open the ureter more. When we splay open the ureter more, even not reducing the pelvis does not matter.
Right. Any more question? Yes, Dr. Rohit.
Asking in cases of child hydronephrosis, the lower pole is really hanging down. Does it only a routine pyeloplasty or it takes some development? Because we have failed giant hydronephrosis, the lower pole is hanging down. Generally, when they have got equivocal.
There's a question. It
Yes,
is a giant hydronephrosis where lower pole is bulging way down to the UPJ. What precaution you take during pyeloplasty?
No, giant hydronephrosis is a really technically difficult term to define. It probably involves multiple vertebral bodies or it's a palpable mass crossing the midline. That is when we call giant hydronephrosis, more than 3 to 4 vertebral bodies. And these patients definitely need a reduction pyeloplasty. But when we reduce the pelvis, we have to ensure that we don't enter into the calyces, because sometimes we tend to overdo the reduction and enter into the calyces. Number two, when we do the anastomosis, we should ensure that we are doing a dependent anastomosis at the bottom end. The bottom end in the sense at 6 o'clock or as low as possible. So, I mean, these are the important points, what I think during a giant hydronephrosis. And we also have to warn the patient that there will be some reduction in the size, residual pelvis, and that doesn't mean that, they have an obstruction. So far, the function improves and the pain is not there, we can consider them as a success.
Any more? आ जाओ तुम.
Sir, in grade 3 or 4 hydronephrosis, sir, and where the function is between 5 to 10%, and Dr. Ramesh Babu has advocated that we should not go for a straightforward nephrectomy, rather we should put a digestate or PCN. And cortical thickness is equally important. And cortical thickness pre-stenting by ultrasound or by post-stenting, or are they the cortical thickness same in both the situations? Because in pre-stented patient, it is stretched out, and the cortical thickness may be lower than the post-stented.
See, there is a question. You mentioned about the importance of cortical thickness.
Yes, sir.
Suppose we do drainage pre-operatively, PCN or BJ stenting, there is a change in the cortical thickness. How to evaluate in such situation? Is it a real improvement or there is a just decreasing in the stretch effect?
A DMSA scan will help, because the DMSA scan is a definite test to show that improvement in function is the real improvement and not just a GFR change because of a DTP. So in that way, when before a nephrectomy, a DMSA is always preferred.
So DMSA is most important. Actually, you cannot assess the thickness in that short duration. Recovery will take longer time.
Yes.
So DMSA scan is very, very important. Any more?
After the started, if the patient has hydronephrosis or patient is symptomatic, and in that particular situation, when we have to intervene further, and what will be the timing, that will be the appropriate for the patient for the further intervention if needed. So this is important because sometimes is supposed to be failed, and in that particular situation, when we intervene the patient for the right result, that will be the question.
Can you repeat that, sir?
Yes. Actually, he said post-pyeloplasty, suppose patient becomes symptomatic after a few months.
Yes.
What is the best time to re-intervene or going for re-operation?
Yes. So we have to wait at least 6 months to 1 year for all that fibrosis and stuff. To usually 6 months, minimum 6 months. I generally wait. If that is not responding, we have to put a stent or a drain, because going back in can be difficult. But a stent usually passes, or a PCN. So we have to buy time for that fibrosis to get better.
Sometimes after the hysterectomy not responding, actually, after removal of the stent, again the patient has the same symptom. So that is I feel that is a very bad situation for the surgeon. But still, what will be the right time to intervene, sir?
See, his answer is wait minimum 6 months
Yes, sir.
and
Minimum 6 months.
try to decompress the system either by PCN or
Yes.
digestion.
Agreed.
So minimum 6 months you should wait.
Yes, sir.
Sir, coming back to giant hydronephrosis, actually we do come across patients where the lower pole is hanging up to L3, L4, the lower calyces. You do a pyeloplasty, post-pyeloplasty, the patient is symptomatic, mild pain is there, the drainage curve is equivocal. When you do a RGP, you feel everything is all right. The PUJ looks great. But you, when you see the RGP, you definitely feel that the lower calyx is below the UPJO. This is very common, particularly in
Yes.
hydronephrotic kidney, where the lower pole is up to
In such cases, we may even do a ureterocalycostomy to do it. But even when you do the ureterocalycostomy, unless you reduce the pelvis will still be hanging and dependent. So it's a very difficult situation. I entirely agree. Large pelvis means that, you sometimes enter into the calyces also if you keep on reducing. So that one has to be careful.
Yes, definitely.
Sir, one of my patients having
Yes, sir.
the ureterocalycostomy was done as a redo procedure, sir, after the post-pyeloplasty. And after the ureterocalycostomy, it was not draining. And then that IVP done, CT scan was done, having the multiple infundibular stenosis at a different level.
Yes.
So how will you tackle that type of patient, sir?
Always
Because it was not draining properly.
Yes.
Even
Primary pyeloplasty is always a better choice than a ureterocalycostomy, and that should be exhausted before one actually, try things about ureterocalycostomy. Don't do ureterocalycostomy as a first choice whenever possible.
Actually, sir, pyeloplasty is something very problematic. Everything you do, still something goes wrong. Recently, we came across a patient where we did a pyeloplasty. Everything was okay for 5 years, but when she became pregnant, she becomes symptomatic.
Yes. No, that can happen. We have to go for a redo pyeloplasty, and redo pyeloplasty sometimes works because we are accessing a longer segment of stenosis, and then it works. Redo pyeloplasty works better than a ureterocalycostomy.
Oh, any more question?
Sometimes the result of pyeloplasty is unpredictable. Sometimes we think that I have not done the good job, still the result is the better. And sometimes after even the good job, the result is not so
Totally
very good.
agree.
That's what Rohit
it is. If you are lucky, you will get good result. Good name. If you are unlucky,
but usually
you will get
pyeloplasty has got a success rate of 95%. So if you are having a 5% recurrent rate, that is reasonably acceptable. Up to 5 to 10% recurrence rate is acceptable.
Okay. Any more
Thank
question?
you so much. We are going to time out in 1
Lastly,
minute.
no. Just a minute.
We are going to time out.
I want to just clarify about the terminology. Should the terminology UPJ or PUJ?
They are both okay, sir. In India, we use PUJ.
Which
in
one?
the US, they use UPJ.
Which one do you believe? One do you believe?
When I'm in India, I use PUJ.
PUJ. Absolutely correct. So it is PUJ. That is retrograde UPJ.
Thank you, sir.
So thank you very much.
Thank you so
we
much.
We really got a lot of input from you, and I think it is very, very beneficial to our member, Bihar Urology Society, and on behalf of Bihar Urology Society, I really thank you very much to be with us this morning. Thank you very much.
Thank you, sir. Thank you, sir.